Welcome to the deep dive. If you are prepping for your nursing assessment exam, well, you know the stakes are high. These mandatory assessment chapters, general survey, vitals, pain, data, culture, skin, and senses, they're really the foundation of everything you will do clinically.
That's absolutely right. Nursing school demands more than just memorization, right? It's about synthesis. You need to know the high-yield information, those testable concepts, the core definitions, and the clinical mechanisms behind them.
So our mission today.
It's a precision deep dive. We're extracting only the absolute gold from your source materials, kind of creating your definitive study guide right here. We want to maximize your attention and really give you the clinical rationale behind the facts.
Okay, sounds good. Let's jump right in then. Starting where every patient encounter begins. Just observing the patient and, quantifying their fundamental status using vital signs. #TagI. General survey, vital signs, and pain. Chapter 7 focus.
The general survey. It's maybe the most underrated assessment tool you have. Seriously. It's that objective observation of the patient, and it starts the moment they walk in or, you enter their room.
And it doesn't stop there, right?
No, it continues right through the assessment until you leave. It gives you those crucial nonverbal cues, the data that tells you which specific questions you really need to ask during the subjective history.
So it's definitely not just a casual glance. It's structured data collection.
Yeah.
What are the key categories, the ones we absolutely have to commit to memory from that essential box 7 one?
Okay, yeah, you have to systematize your observation.
Yeah.
First, overall appearance and apparent age. Does how they look match their stated age? Then move to the neurological baseline, level of consciousness.
Alert, responsive.
Exactly. And orientation, that's person, place, time, and situation. Always check all four. Then observe their facial features and expressions. Look for symmetry, appropriate emotional response, consistency in eye contact.
Yeah, I remember the example of Parkinson's disease, that classic immobile, almost mask-like face.
Precisely. Or, on the flip side, the sort of intense stare you might see with hyperthyroidism. Then we look at their demeanor, their posture, gait, motor activity. Are they avoiding movement?
Which could mean pain.
Often suggests pain, yes. Or do they have involuntary movements, tremors? And finally, you note their speech, their dress, personal hygiene, which can tell you a lot about their baseline function and maybe recent changes, and any obvious skin color issues or lesions.
Okay, so this is where we shift from just observing to actually making clinical deductions. What are some of those hidden clues in how a patient presents, the things that might point us toward a specific pathology?
Right, look for the subtle flags. Excess clothing is a classic one. It might signal cold intolerance, maybe pointing towards hypothyroidism. But it could also be a red flag, Maybe the patient is trying to mask self-mutilation scars or needle marks. You have to consider context.
And you mentioned weight changes specifically related to clothing.
Yeah, if you notice their belt holes have been significantly altered, like way tighter or way looser, that points to a rapid, significant, and maybe unintended weight change. Also, check their footwear.
Footwear? Really?
Yeah. Holes cut in shoes, or maybe they prefer loose slippers. That could indicate painful foot conditions like gout or severe bunions. And if their appearance seems neglected, well, it often suggests depression or maybe dementia. But this is key. You always have to compare it to the patient's known baseline. Is this a sudden change, or is this their norm?
Okay, let's crank up the urgency a bit. When you're doing that initial survey, what are those really high-yield, obvious signs? The ones that scream immediate intervention needed.
You have to instantly recognize distress. For cardiac or respiratory distress, look for the patient clutching their chest, diaphoresis that's profuse sweating, extreme pallor, or obvious labored breathing.
And that classic posture.
The tripod position, yes. Leaning forward, arms braced on their knees, or maybe the chair arms. That's a serious sign of respiratory distress. For pain, look for those nonverbal cues. Grimacing, crying, maybe protecting or holding a specific body part.
And anxiety or depression.
Watch for anxious, fidgety movements, or the opposite. A flat, really inexpressive affect. Often you'll notice cold, moist palms too. Those are all important distress signals. Okay, moving from that general observation to quantification, starting with blood pressure, BP. We need to drill down into the physiology first, just briefly.
Right. Systole is the pressure when the left ventricle contracts, pushing blood out, and diastole is the pressure when the heart muscle is resting and refilling. Seems simple enough, but the accurate technique. That's where things can go wrong, right?
Accuracy is absolutely everything in BP measurement, and exam questions love to test the pitfalls. First, the patient prep is critical. No smoking, no exercise, no caffeine for at least 30 minutes before.
Okay, 30 minutes. Got it.
And they need to sit quietly for 5 minutes. Feet flat on the floor, legs uncrossed. Second, the arm needs to be bare, no clothing, fully exposed. And make sure there are no contraindications like fistulas, significant scarring, or lymphedema.
And the really crucial step involves positioning the arm relative to the heart. What happens if we mess this up? Because I know this comes up a lot.
It does. The brachial artery has to be palpated, and then the cuff position, so the artery is at the level of the heart. Think roughly the fourth intercostal space at the sternum. Now, if the artery is positioned below heart level, gravity causes hydrostatic pressure to artificially increase the reading. You get a falsely high BP.
Okay, below heart level equals high reading.
Right. And if the artery is positioned above heart level, the reading will be falsely low. It's a simple physics thing, but has huge clinical implications.
Definitely. And let's talk about the classic cuff size errors. Yeah. Why does a cuff that's too small give that falsely high reading? What's the mechanism?
Good question. It's because the smaller cuff requires more external pressure to fully compress and occlude the brachial artery. So the pressure reading on the gauge is higher than the true pressure inside the artery. Therefore, a cuff that's too small, too narrow, or even just too loose or ballooning outwards gives you a falsely high reading.
And the opposite, too big.
Conversely, a cuff that's too large, too wide, usually yields a falsely low reading on a small arm because it occludes the artery too easily. Now, it gets a bit tricky because a too wide cuff on a very large arm can sometimes also give a falsely high reading, just due to uneven compression. But the core concept, the one you absolutely have to remember for exams, is small narrow cuff equals falsely high reading.
Okay, small tough, high reading. Got it. Now let's tackle the auscultatory gap. This phenomenon sounds like a really serious clinical pitfall. Can you define it and explain why it's so dangerous if missed?
Yes, the auscultatory gap. It's a silent interval. The Krokoff sounds, the sounds you listen for, they disappear for a period between the systolic and diastolic pressures, and then they return.
Why does that happen?
It's often associated with arterial stiffness and atherosclerotic disease, so finding it should actually flag the patient for a potential further cardiovascular workup. But the immediate clinical danger of an unrecognized gap is huge. You could seriously underestimate the true systolic pressure, or, less commonly, overestimate the diastolic pressure.
Which means, what's the real-world consequence?
It means a patient could have a true BP of, say, 18 to 90, but because those sounds disappear between maybe 170 and 140, you might stop hearing them at 170, then hear nothing, then pick them up again at 140 and think that's...
Palpate first, then inflate 30 above. Got it. Excellent. Let's quickly review the orthostatic procedure and what constitutes a positive finding.
Right. Orthostatic hypotension assessment. It's needed for patients maybe on antihypertensives or those reporting dizziness or fainting. You measure BP and heart rate HR in two positions. First, supine after the patient rests lying down for about 3 to 10 minutes.
Okay, rest first.
Then have them stand up and measure again within 3 minutes of standing. The finding is considered positive for orthostatic hypertension if there's a drop in systolic BP of at least 20 mm Hg, OR, a drop in diastolic BP of at least 10 mm Hg, or sometimes both.
20 systolic or 10 diastolic drop within 3 minutes of standing. Okay, finally for BP, we just need to memorize the Welton 2018 classifications. Can you run through those quickly?
Yep, essential numbers, normal.
Okay.
That's less than 120. Systolic A&D less than 80, diastolic, elevated. Systolic is 120, 120 on A&D. Diastolic is still less than 80. Hypertension stage 1. Systolic is 130, 139 OR. Diastolic is 80, 89. Hypertension stage 2. Systolic is a 140 or greater, or diastolic is 90 or greater.
And the key rule, if the systolic and diastolic fall into different categories.
Always use the higher category. So if your patient's reading is, say, 126/86, the 126 systolic is elevated, but the 86 diastolic falls into stage 1. Therefore, the overall classification is stage 1 hypertension.
Okay, let's move on to temperature. Here, we really need to know the considerations for each route and the mechanism behind why certain routes are more accurate than others.
Right. The average oral temperature is generally considered 37 degrees C or 98.6 degrees Fahrenheit. But remember, it fluctuates naturally throughout the day, usually lowest in the early morning, highest in the late afternoon or evening.
And oral is common, but not always appropriate.
Exactly. Oral is easy and usually reliable, but it just doesn't work well if the patient is agitated, unconscious, can't seal their lips, or if they're mouth breathing due to a rapid respiratory rate. Rectal is technically the gold standard for getting an internal core temperature.
But less convenient.
Oh, much less convenient and more invasive. You need to insert it carefully, about 3 to 4 centimeters, that's roughly 1.5 inches, aiming towards the umbilicus.
Now, why is the tympanic membrane route, the ear thermometer, often considered a reliable estimate of core temperature, even though it's not invasive? This seems important.
This is a really high-yield anatomical fact for exams.
Mm-hmm.
The tympanic membrane shares the exact same arterial blood supply as the hypothalamus.
Ah, the body's thermostat.
Precisely. The body's thermoregulatory center. So that direct blood supply link makes the tympanic route quick and generally reliable if, and this is a big if it's performed properly. That means the ear canal has to be free of significant cerumen or earwax.
Because wax can block the reading.
It can insulate the membrane and lead to falsely low readings. And axillary, under the arm, that's consistently the least accurate route. It usually reads about 1 degree Fahrenheit lower than oral, and it lags significantly behind changes in core body temperature.
Good to know. And just quickly, the terminology for abnormal temperatures.
Fever or pyrexia is just an abnormal elevation. Hyperpyrexia is that extreme elevation defined as above 41.1 degrees C or 106 degrees Fahrenheit. Hypothermia is an abnormally low temp, below 35 degrees C or 95 degrees Fahrenheit, measured rectally.
Any clinical red flags with fever?
Yes. Be really alert for recurrent shaking chills, sometimes called rigors. That severe temperature swing strongly suggests systemic bacteria in the bloodstream. And always remember, the elderly are often less likely to develop a high fever, even with serious infections. So a normal range temp in an older adult doesn't rule out infection. #tag pain assessment, acute versus chronic.
Okay, pain often called the fifth vital sign. Nurses have to approach it multidimensionally. For exams, we definitely need to clearly differentiate the two main classifications.
Absolutely critical distinction. Acute pain is, well, it's a normal protective response. It tends to arise quickly, can be severe, but it's generally short-lived. It's directly associated with a specific physical cause or injury, like surgery or a broken bone. It serves to alert the body to danger.
And chronic pain.
Chronic pain is essentially the opposite. It's considered non-protective or maladaptive. It's defined as pain that persists for more than 3 to 6 months, or pain that recurs frequently over months or years, or even pain that lasts significantly longer, say, more than a month beyond the expected healing time of an acute injury or illness.
And its impact is broader.
Much broader. Chronic pain deeply affects mood, sleep, function, relationships, basically all aspects of life.
When we're assessing the attributes of a patient's pain, we rely on our mnemonic structure. Let's map the comprehensive pain assessment to Old CART again.
Right, Old CART works perfectly for pain too. Onset. When did it start? Was it sudden or gradual? Location. Where exactly is the pain? Can they point to it? Does it radiate? Duration. Is it constant? Does it come and go? Intermittent. Do they have baseline pain with sudden flare-ups? Breakthrough pain. Characteristic symptoms. This is crucial. Severity using a validated scale like 0 to 10. And the quality asked for descriptors. Is it sharp, dull, burning, aching, stabbing, throbbing? Associated manifestations. Are there other symptoms that come with the pain, like nausea, dizziness, numbness, weakness? Relieving factors. What makes it better? What makes it worse? Think rest, ice, heat, specific positions, medications, treatment. What interventions have they already tried? Did they work?
Okay, that's the go. What about neuropathic pain specifically? We need to know about that.
Yes, this is a critical distinction you need to recognize. Neuropathic pain isn't caused by tissue damage in the way acute pain usually is. It results from a direct injury or dysfunction within the peripheral nervous system, PNS, or the central nervous system, CNS itself.
So the nerve signaling is abnormal.
Exactly. And because of that, patients rarely describe it using terms like dull or aching. They typically use very distinct descriptors like burning, lancinating, like an electric shock, stabbing, or pins and needles. And crucially, this type of pain often persists long after the initial injury seems to have healed, because the pain signal processing system itself has been altered or damaged.
That makes sense. Finally, when we're managing chronic pain, especially if we're using opioid analgesics, how do we monitor both treatment efficacy and safety? What's the framework?
We use the 4S framework. It's a standard approach. 1. Analgesia. Is the pain actually being relieved? To what degree? 2. Activities of daily living, ADLs. Is the patient functioning better? Can they work, socialize, perform self-care more easily? 3. Adverse effects. Are they experiencing unacceptable side effects from the treatment? Common ones with opioids include constipation, sedation, nausea. 4. Aberrant drug-related behaviors. Is there any indication of medication misuse, abuse, or diversion? Are they running out early, losing prescriptions, getting drugs from others? 4. Aberrant drug-related behaviors. #tag potential exam questions, Chapter 7.
Okay, let's consolidate. Here are the key concepts you really need to lock down from this first section on general survey, vitals, and pain.
Yep, time to practice that recall.
All right, question one, MC short answer. A nurse places the blood pressure cuff on a patient's arm, but the arm is positioned significantly above the level of the patient's heart. Will this likely result in a falsely high or falsely low reading, and briefly, why?
Question 2, comparison. Think about this. A 35-year-old construction worker comes in describing a new, intense, almost shock-like pain that radiates down his leg. What specific type of pain is this likely describing, and what's its primary physiological cause?
Good one. Question three, critical thinking. According to those Welton guidelines we discussed, how would you classify a blood pressure reading of 100 and 488 millimeter Hg? And what's the specific rationale for assigning it that classification?
And fourth, application. Imagine you're in a critical care setting, and you need the most accurate core body temperature reading possible for your patient. Which route is considered the most reliable for that? And approximately how far should the thermometer be inserted if you use that route? Hashtag 22. Nursing process, data, and cultural competence. Chapter 2, 4, 5 focus.
All right, moving on. This next section really gets to the core of clinical reasoning. It's all about how we gather information, how we process it using essentially the scientific method, and then how we apply it in a culturally appropriate way. Hashtag A, the nursing process.
Exactly. The nursing process, or ADPID, that's assessment, diagnosis analysis, planning, implementation, and evaluation. This is your absolute non-negotiable problem-solving framework for patient care. It's what ensures care is individualized, systematic, and ultimately safe.
And just to be clear, which step are we primarily focused on throughout this whole assessment deep dive we're doing today?
We are squarely in the assessment phase. This phase is all about the comprehensive gathering of patient data. It involves two main parts, taking the health history and performing the physical examination. This is the absolute bedrock. If your assessment data is incomplete or flawed, the entire rest of the plan of care can collapse. Hashtag B, types of patient data.
Okay, let's clarify the fundamental difference between the two main types of patient data. This distinction seems simple, but it's often tested.
Right. It's crucial. First, we have subjective data. Think of these as symptoms. This is the information that is gathered only from the patient's perspective, their feelings, their history as they report it, their chief complaint. Things like, I feel nauseous, or I have a sharp pain right here.
So only the patient can describe or validate it.
Exactly. Only the patient can truly experience and report it. Then we have objective data. Think of these as signs. This is the information that you, the nurse, gather through physical examination, observation, and laboratory or diagnostic tests. It's factual, measurable, and descriptive.
Like what? Give me examples.
Things like observing an erythematous red rash on the skin, getting a BP reading of 1490, measuring a heart rate of 110, or noting a specific lab value like a potassium level. It's data that is, in theory, verifiable by another observer.
Okay, subjective is what they say. Objective is what you see or measure. Once we have a pile of these subjective and objective findings, how do we start making clinical sense of them all?
That's where clinical data clustering comes in. This is a vital step in analysis. You group related signs and symptoms together to try and localize the problem or identify a pattern. For example, if a patient reports a scratchy throat, that's subjective, and then during your exam, you observe an inflamed pharynx with white exudates, that's objective.
You cluster those together.
Right, you cluster those findings, and it points towards a pharyngeal problem. And critically, don't forget this, always remember to cluster relevant psychosocial issues as well. Things like reported stress, family tension, financial worries. These factors directly influence physical health and need to be part of your overall assessment picture.
Makes sense. And when we're interviewing, we rely on old ECART again, but here we're using it maybe more broadly to capture all the attributes of the patient's main complaint or symptom, right?
Yes, exactly. We use old Descartes systematically to make sure we haven't missed any important dimension of the symptom they're presenting with.
Yeah.
Just to recap, onset, location, duration, characteristic symptoms, including quality and severity, associated manifestations, what else happens along with it, relieving factors and aggravating factors, and past treatment, what they've tried before. It ensures a comprehensive description. Hashtag C, principles of clinical evidence and test reliability. Okay, now for some really critical concepts that govern how trustworthy our assessment tools and our findings actually are. We absolutely need to distinguish between reliability and validity. These often get confused.
All right, reliability, that's about precision, consistency.
Exactly. Reliability is precision. It asks, how consistently do repeated measurements give the same result? Think about intra-observer reliability. Can you get the same measurement twice? Or intra-observer reliability, can two different nurses get the same measurement? If you and another nurse measure a patient's liver span and get drastically different numbers, well, you have poor inter-observer reliability. The technique or maybe the tool is inconsistent.
Okay, so reliability is consistency, and validity then is accuracy.
Validity is accuracy, it asks. How closely does the observation or measurement agree with the true state of affairs, or the gold standard? For example, an intra-arterial blood pressure line, the kind you see in the ICU, is considered much more valid than a non-invasive cuff reading because it's a more direct and presumably accurate representation of the true circulatory pressure. The cuff reading might be reliable, you get the same number repeatedly, but less valid than the arterial line.
Got it. Reliability, consistency, validity, accuracy. This brings us to probably the most complex part here. Sensitivity and specificity. These concepts define how useful a screening or diagnostic test actually is. Let's try to unpack SUNOUT and SPIM using some clinical thinking.
Okay, let's break it down. Sensitivity thinks SNOUT. SNOUT stands for high sensitivity, negative result, rules OUT the disease. Sensitivity refers to a test's ability to correctly identify all the people who truly have the condition. These are the true positives.
So it catches everyone with the disease.
Ideally, yes. If a test has high sensitivity and that test result comes back negative, you could be pretty confident in ruling OUT the disease. Why? Because a highly sensitive test has very few false negatives. It rarely misses someone who actually has the condition. Think of it like casting a very wide net designed not to miss anyone with the disease.
Okay, so if I run a highly sensitive test for, say, strep throat, and it comes back negative, I can be reasonably sure the patient doesn't have strep.
Correct. That's the clinical utility of high sensitivity with a negative result. Now let's look at specificity. Think SEP-PIN. SEP-PIN stands for high specificity positive result rules in the target disorder. Specificity is the test's ability to correctly identify all the people who truly do not have the condition. These are the true negatives.
So it correctly identifies the healthy people.
Right. If a test has high specificity and that test result comes back positive, you can be highly confident in ruling in the target disorder. Why? Because a highly specific test has very few false positives. It rarely identifies someone as having the disease when they actually don't.
Okay, that really clarifies the difference. High sensitivity helps you rule out with a negative result, SNOUT, and high specificity helps you rule in with a positive result. Specificity is more about confirmation, while sensitivity is more about screening and exclusion.
You've got it. That's the essence of it, and it's crucial for interpreting diagnostic tests correctly. Hashtag DC. Cultural and spiritual assessment frameworks. Okay, shifting gears a bit. As nurses, we are absolutely serving an increasingly diverse global population. It's essential that we move beyond just, checking boxes on cultural traits and instead embrace the concept of cultural humility. This framework is built on 3 essential dimensions.
And what's the first dimension? The one that really has to happen internally before we even interact with the patient.
That's self-awareness. This requires you, the nurse, to conduct an honest internal self-examination. You need to identify your own personal biases, your stereotypes, your prejudices before you even meet the patient. You have to proactively work to avoid stereotyping. For example, you can't just assume that all patients from a certain region are going to be stoic about pain. That's a harmful generalization.
Right, so check yourself first. What's the second dimension? This involves the interaction itself, right?
Yes, that's respectful communication. This means you have to eliminate assumptions about the patient based on their background. You need to recognize that the patient is the expert on their own culture, their own beliefs, their own experiences. You approach the history-taking process with genuine curiosity and open, non-judgmental inquiry. You learn directly from them.
Okay, self-awareness, then respectful communication, and finally, the outcome of this approach.
That leads to collaborative partnerships. You use that foundation of mutual respect and trust you've built to create a plan of care that is mutually acceptable. It has to be one that respects and incorporates the patient's health beliefs, values, and practices whenever possible and safe.
That makes a lot of sense. Now, a related topic that's often high yield on exams is the spiritual assessment. When is the appropriate timing for this? And maybe more importantly, why is it considered mandatory?
Good question on timing. You can certainly ask about general religious affiliation or practice during the initial admission assessment as part of the social history. However, those deeper, more intimate questions about a patient's spirituality, questions about meaning, purpose, sources of hope, fears, specific spiritual needs or distress, those should generally wait until a trusting relationship has been established. It feels less intrusive then.
And it's mandatory.
Yes. This assessment is not optional. The Joint Commission, JCAHO, the major hospital accrediting body, actually mandates that a spiritual assessment be included as part of their accreditation standards. Hospitals have to show they're addressing this.
Wow, okay. What about some transcultural issues that might impact how we actually take a history or perform an exam? Things we need to be sensitive to.
Definitely. Be acutely aware that cultural expectations significantly affect many nonverbal cues and interaction styles. This includes things like the appropriate amount of time spent in conversation, comfort levels with silence, norms around personal space or physical distance, expectations regarding direct eye contact.
Modesty is a big one too, right?
Huge. Issues of modesty might dictate whether a patient is willing to disrobe or allow examination of certain body parts, especially by a clinician of a different gender. Also, comfort levels with touch vary immensely across cultures, as do the meanings of certain gestures. The key is, if you sense any discomfort or dissonance, it's your responsibility as the nurse to pause, respectfully inquire, and clarify the patient's preferences and boundaries. Hashtags tag potential exam questions. Chapter 2, 4, 5.
Okay, time to lock down these data analysis and cultural concepts.
All right, ready the mental flashcards.
Question 1. High-yield concept. Let's say a diagnostic test used to screen for a fairly rare disease boasts a 99% sensitivity. If a patient you're screening tests negative using this test, what clinical inference can you confidently make? And what's the specific acronym associated with this concept?
Question 2, definition. During your assessment, the nurse notes that a patient is visibly guarding their abdomen when palpated, and you also observe that their skin feels cool and clammy to the touch. Classify each of these two specific findings, the guarding and the cool, clammy skin, as either subjective or objective data.
Nice. Question 3, critical thinking. A nurse recognizes through self-reflection that they hold an implicit bias, assuming that older adult patients are generally confused. According to that framework of cultural humility we discussed, which specific dimension must the nurse consciously address first before continuing with the patient assessment?
And question 4, application. During the interview, a patient reports that their nagging shoulder pain feels significantly better after they use a heating pad and get a gentle massage. Which specific part of the oldie cart mnemonic is being addressed by gathering this particular piece of information? Hashtag tag 3, nutrition and hydration. Chapter 8, focus.
Okay, let's shift to nutrition and hydration assessments. These are so fundamental, really reflecting a patient's internal metabolic balance and fluid status. Let's dive into how we interpret something as basic as weight changes first. Hashtag tag A, nutritional status assessment.
Yes, and this is a really critical distinction for clinical practice and exams. Rapid weight changes. We're talking changes occurring over just a period of a few days, maybe 24, 72 hours. These almost exclusively suggest an increase or decrease in body fluids, not actual tissue mass.
So if a patient in the hospital suddenly gains, say, 8 pounds overnight after receiving AVI fluids, that's not fat gain, that's fluid overload.
Precisely. Think aggressive IV hydration or conversely, rapid fluid loss from aggressive diuresis or maybe severe vomiting diarrhea.
Yeah.
Now, on the other hand, slow, gradual, often unintended weight changes over weeks or months. That suggests true shifts in body tissues, muscle, or fat. It points toward things like a chronic caloric imbalance, eating too much or too little, maybe malabsorption issues, or possibly increased metabolic needs from an underlying disease.
You mentioned a fascinating clinical clue related to weight loss.
Right. Unintended weight loss, despite the patient reporting a high or seemingly normal food intake. That specific pattern should immediately make you consider diseases that significantly increase the body's metabolic rate. Top contenders are often hyperthyroidism, poorly controlled diabetes mellitus, where glucose isn't getting into cells for energy, or sometimes behavioral issues like bulimia nervosa, where there's clandestine vomiting after eating.
Good pointers. Now let's focus on the physical signs of specific nutrient deficiencies. These are highly testable because they require you to link a physical finding back to a specific vitamin or mineral deficit, showing that systemic understanding.
Exactly. We have to be able to connect the dots. Let's look at some key ones by system. Skin hair nails. Dry, flaky, rough skin might indicate vitamin A, some B vitamins, or essential fatty acid like linoleic acid deficiency. Definitely know this one. Petechiae, small pinpoint bruises, or ecchymoses, larger bruises, strongly suggest a deficiency in vitamin C or vitamin K, both of which are crucial for capillary integrity and blood clotting.
Okay, bruising points to C or K. What about hair and nails?
Thin, sparse, dry, brittle hair often suggests significant protein deficiency, and the classic nail finding. Spoon-shaped nails, where they're concave, that's called koilonychia, and it's the hallmark sign of chronic iron deficiency.
Spoon nails and deficiency. Got it. What about the mouth and throat?
A smooth, magenta-colored tongue, purplish red, points towards riboflavin, vitamin B2 deficiency. A very sore, swollen, beefy red tongue suggests vitamin B12 deficiency. And visible swelling in the neck, a goiter, classically suggests iodine deficiency, which is needed for thyroid hormone synthesis.
And musculoskeletal signs.
Obvious muscle wasting, especially in the limbs and temporal areas, suggests protein-calorie malnutrition deficiency in protein, carbs, and fats overall. Bone pain, tenderness, or skeletal deformities like bow legs in children point towards vitamin D or calcium deficiency, both essential for bone health. #B, hydration status. Dehydration versus overhydration.
Okay, moving from nutrition to hydration, we absolutely need to be able to differentiate the signs and symptoms of volume depletion versus volume excess because obviously their management is completely opposite.
Critical comparison. Let's lay out the key findings side by side. Dehydration, deficient fluid volume. Think hypovolemia, not enough circulating volume. The patient typically experiences short-term weight loss. That's the fluid. You'll observe dry mucous membranes, mouth, eyes, maybe sunken eyes. Fever can sometimes occur. And importantly, decreased skin turgor. Skin tense when pinched. Hemodynamically, you expect decreased blood pressure and often a narrowed pulse pressure. But a compensatory increased pulse rate, tachycardia, as the heart tries to maintain cardiac output. Urine output will likely be decreased as the body tries to conserve fluid. Severe dehydration can cause altered mental status.
Okay, so low volume leads to dry signs, low BP, high heart rate. What about overhydration?
Overhydration, excess fluid volume. Think hypervolemia, too much circulating volume. Here, the patient has short-term weight gain, fluid again. You'll see peripheral edema, swelling in feet, ankles, hands, often elevated blood pressure. The pulse might feel decreased if cardiac function is impaired, or it could be strong and bounding due to the high volume. Key signs of high central volume, meaning fluid backing up towards the heart and lungs, include jugular vein distension, GVD in the neck, potentially hearing an extra S3 heart sound on auscultation, and often hearing fine crackles in the lung bases due to fluid moving into the alveoli. This can cause shortness of breath, dyspnea, and also altered mental status in severe cases.
So if a patient presents with that combination of a bounding pulse and fine crackles in their lungs, that combination immediately tells you they are likely severely fluid overloaded, right?
Absolutely. The bounding pulse reflects that high fluid volume being pumped, often against increased resistance, and the crackles are a direct sign of fluid backing up into the pulmonary circulation. That's a classic picture of volume excess. #CZ body mass index, BMI, and risk classification.
Okay, let's talk BMI. It's a common screening tool, useful, but it doesn't quite tell the whole story about risk, does it? We need to know the classifications and, crucially, when to take further measurement.
Exactly right. BMI is calculated based on height and weight. You don't need to memorize the formula usually, but you do need to know the classification cutoffs. These are standard: underweight, BMI less than 18.5, normal weight, BMI 18.5 up to 24.9, overweight, BMI 25.0 up to 29.9, obesity class 1, BMI 30.0 up to 34.9, obesity class 1. And it continues with class 2 and 3, but those are the main ones to know initially.
Now, the critical point here is that where the fat is located matters. Central body fat around the abdomen poses a much higher metabolic risk than fat stored peripherally, like in the hips and thighs. So when does a nurse absolutely need to follow up that BMI calculation by assessing waist circumference?
This is key. You should measure waist circumference if the patient's BMI falls into the overweight or obesity class I categories, especially if they have other cardiovascular risk factors like hypertension or high cholesterol. It's also generally recommended if the BMI is 35 or greater, although at that point, the risk is already considered high. Waist circumference indicates excess abdominal fat, which is strongly linked to increased risk if it measures. 35 inches or greater for women, or 40 inches or greater for men.
35 for women, 40 for men. Got it. That central obesity measure significantly correlates with heart disease, type 2 diabetes, and metabolic syndrome risk.
Precisely. And remember this important health promotion nugget you can share with patients. Even a relatively modest weight reduction, just 5% to 10% of their current body weight, can result in significant improvements in blood pressure, lipid levels, cholesterol and triglycerides, and glucose tolerance. It doesn't always require massive weight loss to see health benefits. ## potential exam questions, Chapter 8.
All right, let's focus on those comparisons and the deficiency links for review.
Okay, time for some application. Let's test it.
Question 1. Differentiating findings. A patient you're assessing has noticeably sunken eyes, poor skin turgor, it tense when pinched, and you measure their pulse rate at 115 beats per minute. Does this cluster of signs suggest deficient fluid volume, dehydration, or excess fluid volume, overhydration? And what's the likely physiological mechanism causing that increased pulse rate?
Question 2. Definition recall. During your assessment, a nurse notes that a patient has thin, brittle hair that breaks easily and also observes that their tongue has a distinct magenta or purplish-red color. What are the two specific nutritional deficiencies most strongly suggested by these combined findings?
Good one. Question 3. Critical thinking. A patient is classified as having obesity class I with a calculated BMI of 31.0 kg when a Disney starts. What essential next assessment step must the nurse perform to more accurately gauge this patient's specific cardiovascular risks related to their body composition?
And number 4, mechanism. Explain the clinical significance if a patient reports losing 10 pounds over the past 48 hours after starting a new diuretic medication. What physiological component is this rapid weight loss primarily related to? Hashtag div Phi. Skin, hair, and nails assessment. Chapter 9 focus.
Okay, shifting focus now to the integumentary system, the skin, hair, and nails. The skin is our largest organ, and it provides so many crucial diagnostic clues about both local issues and systemic diseases. Let's start with the basic microscopic structure, hashtag AFI, skin anatomy and function.
Right, we have 3 primary layers to remember. The outermost is the epidermis. It's relatively thin, and critically, it's avascular, meaning it has no direct blood supply. It gets all its nutrients by diffusion from the layer below. Keratinized cells are constantly migrating from the basal layer up to the surface, where they're shed. This entire turnover process takes roughly 1 month.
1 month for epidermal turnover. Okay, what's below that?
Below that is the dermis. This is a much thicker layer, and unlike the epidermis, it's richly supplied with blood vessels, nerve endings, hair follicles, and various glands. It also contains connective tissue, primarily collagen and elastin, which gives the skin its strength and flexibility. And deepest of all is the subcutaneous layer, also called the hypodermis, which is composed primarily of adipose tissue or fat. It provides insulation, energy storage, and cushioning.
Got it. Now, the amazing variety of human skin color comes down to just 4 main pigments influencing what we see. Can you list those?
Sure. The primary one is melanin, which produces the brownish pigment. The amount is genetically determined but can be increased by sun exposure. Then there's keratin, which gives a golden yellow color. It's found in subcutaneous fat and is often more noticeable in areas where the epidermis is thin, like the palms and soles. Third is oxyhemoglobin, the bright red pigment in arterial blood. Increased blood flow to the dermis makes this more visible, causing reddening or flushing. And lastly, deoxyhemoglobin, which is the darker bluer pigment seen when hemoglobin has released its oxygen. An increase in deoxyhemoglobin in superficial vessels leads to cyanosis.
Okay, melanin, keratin, oxyhemoglobin, deoxyhemoglobin. Let's nail down the difference between the 3 key types of skin glands, especially where they are located or, importantly, not located.
Right, the glands are important. First, sebaceous glands. These produce sebum, which is an oily substance that lubricates the hair and skin and helps reduce water loss. Crucially, sebaceous glands are found everywhere except the palms and soles. That's a key distinguishing fact.
No sebaceous glands on palms and soles. Okay.
Second, icrangue glands. These are the major sweat glands, and they're widely distributed all over the body. They open directly onto the skin surface, and their primary function is thermoregulation, controlling body temperature through sweat evaporation. Third, epicrine glands. These are mostly found in the axillary, armpit, and genital regions. Unlike icrangue glands, they usually open into hair follicles. They become active at puberty and are stimulated by emotional stress. The sweat they produce is initially odorless, but bacteria on the skin decompose it, producing characteristic adult body odor. Hashtag B, skin color clues, exam recognition. Okay, when we're assessing for abnormal skin colors like jaundice or cyanosis, where should the nurse look most carefully, especially when assessing patients who have naturally darker skin tones where these changes might be less obvious? Excellent point. For jaundice, which is the yellowing due to excess bilirubin, the easiest and most reliable place to detect it, regardless of skin tone, is in the sclera, the white part of the eyes. You can also often see it on the hard palate, roof of the mouth, under the tongue, and sometimes on the nails, palms, and soles.
Sclera first for jaundice and for cyanosis.
For cyanosis, the bluish discoloration from low oxygenated hemoglobin, you should look at the lips, the oral mucosa inside the mouth, the tongue, the nail beds, and also the palms and soles, especially in darker-skinned individuals where it might be harder to see elsewhere. Remember to differentiate between peripheral cyanosis, often due to cold or decreased blood flow like in heart failure, and central cyanosis, seen in the tongue and oral mucosa, indicating more severe systemic hypoxemia, like in pulmonary edema. Hashtag see lesions and documentation. When you find any skin lesion, whether it's a primary lesion like a vesicle or papule that arises first, or a secondary lesion, something that results from changes to a primary lesion like crusting or scaling, Precise documentation is absolutely key for tracking changes. Your documentation checklist must include several characteristics.
Okay, what are the must-haves for describing a lesion?
You need color, and does it blanch? Size, measure accurately with a ruler in millimeters or centimeters. Elevation, is it flat like a macule, raised like a papule or nodule, or fluid-filled like a vesicle or bulla? Number, single or multiple? Texture, is it smooth, fleshy, rough verrucous, or scaly keratotic? Shape and pattern, is it roundangular, linear, grouped, or does it follow a specific pattern like a dermatome? And finally, its anatomic location and distribution. Where on the body is it, and is it localized, generalized, or following a typical pattern for certain conditions?
You emphasize shape and pattern. Can you give us a high-yield example where the pattern is almost diagnostic?
Absolutely.
Yeah.
The classic example is seeing vesicles, small fluid-filled blisters that are clustered together in a unilateral dermatomal pattern, meaning they follow the path of a single spinal nerve root on one side of the body. That specific pattern is pathognomonic, virtually diagnostic for herpes zoster or shingles. Also remember common distributions. Acne typically affects the face, chest, and back. Psoriasis often favors the elbows, knees, scalp, and lower back. Candida yeast infections love warm, moist skin folds. Those are called intertriginous areas.
Got it. Dermatomal pattern equals shingles. And what's the specific process we must perform for any new red lesion or rash to help determine its cause?
You must perform the blanching test. You press the red lesion firmly with your finger, or even better, a clear glass slide. If the redness temporarily disappears, blanches, and then quickly returns when you release the pressure, capillary refill, that strongly suggests the redness is due to vasodilation, dilated blood vessels from inflammation. If the redness does not blanch, it suggests the red color is from extravasated blood that is leaked out of the vessels into the tissue, like in petechiae or purpura. Blanching versus non-blanching is a key differential. #HeadCheckD. Pressure injuries. Risk assessment. Pressure injuries, formerly called pressure ulcers or bed sores, are unfortunately common, but also highly preventable with good nursing care. The mechanism involves sustained compression, usually over a bony prominence, which obliterates capillary blood flow to the skin and underlying tissues. This leads to tissue ischemia, lack of oxygen, and eventually necrosis, tissue death.
And other forces contribute too.
Yes, shearing forces, like when a patient slides down in bed, causing deeper tissue layers to slide against each other and distort blood vessels, and friction, rubbing against sheets, significantly increase the risk. Moisture from incontinence or sweat also weakens the skin and makes it more susceptible.
What's the single most important early warning sign we need to look for on the skin?
Local redness of the skin that does not blanch with pressure. This persistent redness, called non-blanchable erythema, is the key warning sign of impending tissue necrosis. It indicates that capillary damage has already occurred. If you see this, you need to implement pressure-relieving interventions immediately.
And how do we systematically assess a patient's risk for developing pressure injuries?
We use a standardized tool, most commonly the Braden scale. This scale quantifies risk by assessing 6 independent risk categories or factors. You need to know these. Sensory perception, can they feel pain pressure? Moisture, is the skin excessively moist? Activity, do they walk? Mobility, can they change position independently? Nutrition, is their intake adequate? And friction shear. A lower total score on the Braden scale indicates a higher risk for developing a pressure injury. #E melanoma screening. A, B, C, D, E, E, F, G.
Okay, let's talk about skin cancer, specifically melanoma. It's the most lethal form primarily because it has a high potential for metastasis. Thorough screening using the recognized criteria is mandatory.
Absolutely. Early detection is key. We use the standard ABCDE method for screening most pigmented lesions, like moles. Asymmetry. One half of the lesion does not look like the other half. Border. The edges are irregular, notched, ragged, or blurred. A normal mole usually has smooth, even borders. Color. There's variation in color within the lesion. Look for shades of tan, brown, black, and sometimes even white, red, or blue. Benign moles are usually a single shade of brown. Diameter. Generally, melanomas are larger than 6 millimeters, about the size of a pencil eraser, or any lesion that looks significantly different or larger than the patient's other moles, the ugly duckling sign. Evolving changing. This is arguably the single most sensitive criterion. Any change in an existing mole in its size, shape, color, elevation, or symptoms like itching or bleeding is suspicious.
ABCE for most moles, but you also mentioned EFG for the more aggressive nodular type melanomas.
Yes, some melanomas don't fit the classic ABCDE pattern well, especially nodular melanomas, which tend to grow vertically quickly. For these, we add the EFG criteria, elevated. The lesion is raised significantly above the skin surface, firm. It feels firm or hard to the touch, growing. It shows progressive growth over a relatively short period, maybe just weeks or a couple of months. And remember the key risk factors for melanoma? Having many moles, 50 or more common moles, a personal or family history of melanoma, being male, having fair skin, light hair that burns easily, and significant sun exposure history. And remember the key risk factors for melanoma. Hashtag potential exam questions. Chapter 9.
Okay, time to review these integumentary system concepts. Focus on function, mechanism, and those key identifiers.
Right, focus on linking the finding to the underlying principle or condition.
Question 1. MC definition. A patient presents with a generalized yellow tint to their skin, particularly noticeable on their palms and soles, but their sclera, the whites of their eyes, and hard palate remain perfectly pink-white. What common golden yellow pigment, often related to diet, might be responsible for this non-pathological finding, distinguishing it from true jaundice?
Question 2. Application. A nurse observes a cluster of small fluid-filled blisters, vesicles, that cover the right side of the patient's upper back. The blisters seem to follow a clear, linear band extending from near the spine towards the side of the abdomen, stopping abruptly at the midline. What specific clinical condition does this distinctive pattern strongly suggest?
Question 3. Risk factor recall. List the 3 specific categories assessed by the Braden scale that relate directly to a patient's ability to physically move themselves and to feel or respond to pressure-related discomfort.
In question 4, process prioritization. If a 45-year-old patient reports during a skin check that one of their long-standing moles has recently changed color significantly and seems to have gotten noticeably larger over the past few months, which single criterion of the ABCDE melanoma framework is considered the most critical or sensitive indicator warranting urgent referral? Hashtag V, head, neck, and headaches. Chapter 10, focus.
All right, let's move up to the head and neck. Headaches are incredibly common complaints in almost any setting. The absolute priority here is learning to rapidly triage distinguishing those benign primary headaches from potentially life-threatening secondary causes.
Exactly. We must screen every patient presenting with a significant headache for specific red flags that suggest a more worrisome underlying cause, like subarachnoid hemorrhage, meningitis, or maybe the tumor. The best way to remember these is using the powerful screening tool, the mnemonic SNOO.
Okay, let's detail SNOP, starting with S. What are the most alarming systemic symptoms or signs we look for? S is for systemic signs or illness. This includes the patient describing the headache as the absolute worst headache of my life. That's a classic descriptor for subarachnoid hemorrhage. Also, associated symptoms like fever, unexplained weight loss, markedly elevated blood pressure, or signs of meningitis like a stiff neck, neutral rigidity. A history of cancer or HIV also raises concern for secondary causes like metastasis or infection. Okay, S is systemic. What about N? N is for neurologic deficits. Any new or associated neurological symptom is a major red flag. This includes any altered mental status, confusion, lethargy, new onset seizures, or physical findings like papilledema, swelling of the optic nerve head seen on fundoscopic exam, or focal neurological signs like unilateral weakness or numbness. O. There are 2 O's. O is for onset. This is crucial. A headache with a new or sudden onset, especially if the patient is over age 50 and has never had headaches like this before. Or, even more alarming, the terrifyingly acute thunderclap headache, which reaches its maximum intensity in literally under 1 minute. That screams vascular event, usually hemorrhage. The second O is for other associated conditions or features. This includes a headache that begins after significant head trauma, or a headache that is clearly made worse by changes in position, like bending over, or by the Valsalva maneuver, things like coughing, sneezing, or straining. And finally, PP is for prior history. This means a significant change from their usual headache pattern. If they have a history of migraines, but this headache is drastically different in its progression, pattern, frequency, or severity than any they've had before, that's a red flag too. That's a great framework. What about the chronological pattern? You mentioned onset, but what pattern over time should make us worry specifically about an intracranial mass or tumor?
New headaches that start insidiously, but are progressively severe, and maybe increase in frequency or persistence over days or weeks. That pattern really raises the concern for a space-occupying lesion like a tumor or an abscess. Again, contrast that with the sudden, severe onset suggesting a vascular event like hemorrhage.
Good distinction. And one more assessment trap related to headaches.
Yes, always ask about medication use. Patients who take symptomatic headache medication, whether it's over-the-counter stuff like Tylenol or ibuprofen, or prescription meds like triptans for migraines if they take these more than 2 days a week on average, they may actually be suffering from a medication overuse headache, also called rebound headache. The treatment paradoxically involves stopping the overused medication.
Right. Okay, let's quickly compare the three main primary headache types: tension, migraine, and cluster. We really need the key differentiating features down cold, especially location and quality.
Okay, let's hit the highlights. Tension headache. Typically bilateral, often described as feeling like a tight band around the head or pressure over the entire scalp. The quality is usually a steady pressing or tightening sensation, not throbbing. Intensity is generally mild to moderate. It can last anywhere from 30 minutes to 7 days and often feels better with relaxation, massage, or mild analgesics. Migraine headache. Often unilateral, about 70% are on one side, though it can switch sides or be bilateral. The quality is typically throbbing, pounding, or aching. Intensity is moderate to severe, often disabling. About 30% are preceded by an aura, usually visual disturbances like flashing lights or blind spots, but could be sensory like tingling. Migraines typically last 4 to 72 hours and are characteristically aggravated by routine physical activity, noise, phonophobia, and/or light, photophobia. Nausea and vomiting are also common. Cluster headache. These are strictly unilateral, almost always localized intensely in or around one eye or the temple. The quality is described as excruciatingly sharp, boring, or burning extremely severe. They are relatively short-lived but agonizing, lasting typically 15 minutes to 3 hours. But they occur in clusters, multiple attacks per day for weeks or months, followed by remission. Critically, they are associated with ipsilateral, same side, autonomic symptoms like redness and tearing of the eye, lacrimation, drooping eyelids, peptitosis, runny or stuffy nose, right, or recongestion. Cluster headache. Hashtag B, thyroid assessment. Okay, moving down to the neck. Let's focus on the thyroid gland. The thyroid controls metabolism, so when we assess it, we're primarily looking for signs and symptoms of either hypofunction, too little hormone, or hyperfunction, too much hormone, based on the effect on the body's metabolic rate.
Let's contrast those high-yield symptoms side by side. Hypo versus hyper.
Okay, hypothyroidism, think low and slow metabolism. Key symptoms include cold intolerance. The patient often prefers warm clothing or environments, even when others are comfortable. Decreased sweating, persistent fatigue and lethargy, constipation, weight gain despite normal or decreased appetite, coarse, dry hair and skin, sometimes hoarseness and swelling, particularly of the face, myxedema, hands and legs.
Okay, cold, tired, constipated, gaining weight, coarse hair. What about hyperthyroidism?
Hyperthyroidism, think high and fast metabolism. Key symptoms include heat intolerance and excessive sweating, nervousness, anxiety, irritability, weight loss despite increased appetite, palpitations or rapid heart rate, frequent bowel movements or diarrhea, and often fine silky hair, sometimes bulging eyes, exophthalmos, and Graves' disease.
Heat intolerance, anxious, losing weight, fast heart rate, fine hair. Got it. Now, for the physical exam itself, specifically when palpating the thyroid gland using the preferred posterior approach, standing behind the patient, what specific instruction do you give the patient regarding their neck position to make palpation easier?
This technique point is crucial. You must ask the patient to flex their neck slightly forward. This specific action helps to relax the large neck muscles overlying the thyroid, particularly the sternocleidomastoids. Relaxing these muscles makes it much easier for you to identify the key landmarks, the cricoid cartilage and the thyroid cartilage above it, and then to feel the thyroid isthmus and lobes more distinctly. Then, you ask them to sip and swallow some water while you palpate, feeling the gland rise and fall.
Flex neck forward to relax the SEMs. Okay. And besides size and shape, what abnormal sounds might we listen for over the thyroid gland?
If the thyroid gland feels enlarged on palpation, you should auscultate over the lateral lobes using the bell of your stethoscope. You might hear a bruit. A thyroid bruit is a soft, rushing vascular sound, like a non-cardiac murmur. It's created by the increased turbulent blood flow through a hyperactive gland, and hearing one strongly suggests hyperthyroidism, particularly Graves' disease.
So an enlarged thyroid plus a bruit points strongly to hyperthyroidism. What about the consistency?
Yes, the consistency on palpation also gives clues. A diffusely enlarged but soft gland is typical of Graves' disease. A firm or rubbery consistency often suggests Hashimoto's thyroiditis, an autoimmune cause of hypothyroidism. And if the gland is tender to palpation, that suggests acute thyroiditis inflammation. Hashtag Z. Traumatic brain injury, TBI prevention. Just a quick but important note on TBI prevention, as this is a mandatory counseling topic, especially in primary care and emergency settings. We need to know the leading causes to target our advice. They vary sharply by age group.
Right. What are the big ones?
Falls are the dominant cause overall, but especially in the very young, children 0 to 17, and importantly in older adults, age 55 and over. For adolescents and younger to middle-aged adults, roughly 1544, motor vehicle accidents, MVAs, are often the leading cause. Being hit or struck by an object is another common cause across many age groups.
Okay, falls for young and old, MVAs for the middle group. So what high-yield prevention advice should we routinely provide in a clinical setting based on those causes?
We really focus on mitigating the risks from falls and vehicle accidents. For fall prevention, especially for older adults, recommend installing grab bars in bathrooms, using non-slip mats in tubs and showers, removing or securing throw rugs, ensuring adequate lighting and using handrails on stairs. Encourage wearing well-fitting non-slip shoes. For MVA prevention, always emphasize seatbelt use for everyone in the car. Ensure infants and children are in appropriate, correctly installed car seats or booster seats. And strongly emphasize that small children should always be placed in the back seat, especially if the car has a passenger side airbag, due to injury risk.
And helmet.
Absolutely. Promote consistent use of helmets for activities like bicycling, motorcycling, skateboarding, skiing, and contact sports. And for households with firearms, counsel on safe storage, locking guns and ammunition separately. #tag essential exam questions. Chapter 10.
Okay, let's review those headache red flags and the thyroid differentials.
Final check on the head and neck assessment points.
Question 1. MCS-NOOP application. A 55-year-old patient reports a new onset, dull, non-throbbing headache that seems to have gradually worsened in intensity over the last 3 weeks. They've never had headaches like this before. Which specific element of the SNOP mnemonic is the most concerning red flag in this particular scenario? And what general type of underlying pathology does this specific temporal pattern, progressive worsening over weeks, often suggest?
Question 2. Technique, process, and finding. During the thyroid exam, using the posterior approach, the nurse palpates a symmetrically enlarged, soft thyroid gland. Upon auscultation over the lateral lobes, the nurse clearly hears a bruit. What specific thyroid condition is this combination of findings highly suggestive of?
Question 3. Comparison. Let's compare symptoms. One patient reports constantly feeling cold and being chronically fatigued. Another patient complains of fine tremors in their hands and excessive sweating. Which thyroid condition, hyper or hypo, is typically associated with the fatigue and cold intolerance, and which condition is typically associated with the tremors and sweating?
And question 4. Assessment rationale. When obtaining a detailed headache history, the nurse specifically asks the patient if the pain is aggravated or made worse by coughing or straining. Which specific part of the SNOP mnemonic is the nurse directly addressing with this question, and why is that information relevant in screening for potentially serious causes? #tag site. Eye assessment, Chapter 11. Focus.
All right, let's turn our attention now to the sensory organs, beginning with the eye. The eye exam is so important. It's a crucial window into both local eye diseases and also can reveal signs of many systemic diseases. #tag AA anatomy and vision changes.
Absolutely. When we perform a fundoscopic exam and look into the back of the eye of the fundus, we need to be able to recognize the key anatomical landmarks. These include the retina, the light-sensing tissue lining the back, the choroid, the vascular layer beneath the retina, the fovea, a small depression in the macula that provides the absolute sharpest central vision, the macula, the area surrounding the fovea responsible for central high acuity vision, and importantly, the optic disc.
And the optic disc is key because
It's the entry point for the optic nerve, CNTI, and the major retinal blood vessels. It's often used as the primary landmark for orienting yourself during the fundoscopic exam. You measure distances and locate lesions relative to the optic disc diameter.
Okay. Now, how is intraocular pressure regulated within the eye? And why does understanding this matter so much clinically, especially regarding glaucoma?
Intraocular pressure, IOP, is primarily controlled by the continuous production and drainage of aqueous humor. This fluid is produced by the ciliary body, located behind the iris. It then circulates from the posterior chamber behind the iris through the pupil into the anterior chamber in front of the iris, and finally, it drains out of the eye through a meshwork and into the canal of Schlemm, located in the angle where the iris meets the cornea.
So if that drainage is blocked,
Exactly. If that drainage pathway, particularly the canal of Schlemm or the trabecular meshwork leading to it, becomes blocked or obstructed, the aqueous humor can't drain properly. Pressure builds up inside the eye, leading to increased IOP, which is the hallmark of glaucoma. This high pressure can damage the optic nerve over time, causing irreversible vision loss.
that's critical. Recognizing emergent symptoms of vision loss is also paramount. What are the major warning signs related to vision that require immediate ophthalmology referral?
Okay, these are absolute emergencies. Sudden, painless unilateral vision loss. This is a huge red flag. Top considerations include a vitreous hemorrhage, bleeding into the vitreous gel, often seen in diabetics, an acute retinal detachment, or possibly macular degeneration, though that's often more gradual, sudden, painful unilateral vision loss. This also requires immediate attention. Think about conditions affecting the front of the eye like a corneal ulcer or inflammation like uveitis. But the most immediately sight-threatening cause is acute angle closure glaucoma, where that drainage angle slams shut, suddenly causing intense pain and very high IOP.
Painless sudden loss versus painful sudden loss, different causes, both emergencies. And what specific symptom often heralds a retinal detachment actually occurring?
The classic symptom is the sudden appearance of flashing lights, photopsia, often described like lightning streaks, accompanied by a shower of new vitreous floaters which look like moving specks, strands, or cobwebs in the field of vision. This combination strongly suggests that the vitreous gel is pulling away from or tearing the retina, which can lead to detachment. This needs prompt consultation.
And how do we distinguish those moving floaters from fixed spots?
Good point. Those moving specks or strands, floaters, are usually benign shadows cast by debris within the vitreous gel. However, fixed defects or blind spots, scotomas, in the visual field that don't move usually indicate a lesion in the retina itself or along the visual pathways in the brain.
Okay, let's quickly review the basic refractive errors, trouble focusing.
Right. Difficulty seeing far objects clearly is myopia, commonly known as nearsightedness. Difficulty seeing close objects clearly is hyperopia, or farsightedness. And then there's presbyopia.
Which is related to aging.
Yes, presbyopia is the very common age-related loss of the lens's ability to accommodate, meaning it loses its elasticity and can no longer change shape sufficiently to focus on near objects. This typically starts to become noticeable after age 40, and is why many middle-aged adults start needing reading glasses. Hashtag NESTB. Visual acuity testing, distal and near. Okay, testing visual acuity. Distal visual acuity checking far vision is routinely tested using the Snellen eye chart. The patient stands at a standardized distance, which is 20 feet away from the chart.
Right. And how do we properly document the result if, say, they can only read the line marked 40 from 20 feet away?
That result is documented as 20/40. The numerator, the first number 20, always represents the distance the patient is standing from the chart, in feet. The denominator, the second number 40, represents the distance at which a person with normal vision could read that same line. So 20/40 means the patient needs to be at 20 feet to read what a person with normal vision can read from 40 feet away.
And normal vision is?
Normal acuity is considered 20/20. Legal blindness in the U.S. is typically defined as best-corrected visual acuity worse than 2200 in the better eye, or a visual field restricted to 20 degrees or less. As a clinical standard for screening, the general guideline is to refer the patient for further ophthalmologic evaluation if their best-corrected vision, meaning with their glasses or contacts if they wear them, is worse than 20/30, and for near vision.
For near vision, we typically use a handheld card like the Jaeger or Rosenbaum card, which the patient holds at a standard distance of 14 inches from their eyes. Normal near vision is recorded as 14/14, or sometimes using the Jaeger notation, like J1 or J2 being normal. Difficulty reading the small print on this card, especially in adults over 40, confirms presbyopia. Hashtag C. External and extraocular movement, EOM assessment. Okay, moving to the external eye exam and eye movements, we can actually gather some interesting systemic clues just by looking at the outside structures, right?
Absolutely. Look carefully at the eyebrows. Lateral sparseness of the eyebrows, meaning thinning or loss of the outer third, can be a subtle but classic sign of hypothyroidism. Look at the sclera color again, distinct yellowing points to jaundice, liver disease, or hemolysis.
And when we're testing the extraocular movements, EOMs, by having the patient follow our finger through the 6 cardinal fields of gaze, what abnormal movement are we looking for?
We're primarily looking for nystagmus, which is a fine, rhythmic, involuntary oscillation or beating of the eyes. It's important to note that a few beats of nystagmus upon extreme lateral gaze can be perfectly normal. However, sustained nystagmus, especially within the normal binocular field of gaze, not just at the extremes, is abnormal and usually points to neurological issues like cerebellar or brainstem problems, or sometimes inner ear dysfunction affecting balance.
Okay, sustained nystagmus is abnormal. What's the high-risk finding related to glaucoma that we might see during the external assessment, even before looking inside the eye?
When you shine a light obliquely from the side across the iris, you're trying to assess the depth of the anterior chamber. That's the space between the front of the iris and the back of the cornea. If the iris seems to bow forward significantly, creating a very shallow chamber and a narrow angle where it meets the cornea peripherally, that patient is at high risk for acute narrow angle closure glaucoma. This happens if the iris suddenly bunches up and blocks the drainage canal completely. It's an emergency. In contrast, an open angle means the normal spatial relationship is preserved. This is seen in the more common open-angle glaucoma.
Narrow angle equals glaucoma risk. Got it. And the famous pupillary assessment acronym we all have to chart?
That would be PERAL-LA, which stands for pupils equal, round, reactive to light, both directly and consensually, and accommodation, meaning the pupils constrict appropriately when the patient shifts focus from a distant object to a near object and the eyes converge. You should always measure and document the pupil size. Normal is typically 3 to 5 millimeter. Note if they are large, mydriasis 5 millimeters, small, meiosis 3 millimeters, or unequal, anisocoria. #tag potential exam questions, Chapter 11.
Okay, let's consolidate the eye assessment, focus on the anatomy, the emergencies, and the key findings.
Right, time to synthesize this visual information.
Question 1. MC pathophysiology. A patient calls the clinic reporting the sudden onset of seeing flashing lights in the periphery of one eye, along with numerous new cobwebs or floaters drifting in their vision. What potential emergent ophthalmologic condition does this specific combination of symptoms strongly suggest? And briefly, why are these symptoms occurring?
Question 2, anatomy. When a nurse is performing a fundoscopic examination to visualize the back of the eye, they often use the entry point of the optic nerve and major blood vessels as a primary reference point for locating other structures. What is the correct anatomical name for this specific structure?
Question 3. Assessment data and action. During a vision screening using the Snellen chart, a patient stands 20 feet away and is only able to read the line marked 50 with their corrective lenses on. How should the nurse accurately record this visual acuity finding? And based on common referral guidelines, what is the maximum acuity level, for example 20, that generally warrants referral to an ophthalmologist?
And question 4, definition and cause. A 42-year-old teacher complains to the nurse that over the past year he's found it increasingly difficult to read small print, especially in dim light, often needing to hold his reading material further away from his face to see it clearly. What is the specific name for this common age-related vision condition, and what is the underlying physiological cause related to the eye's lens? #TagCheck7, ear, nose, mouth, and throat. Chapter 12, focus.
Okay, our final deep dive section covers the ear, nose, mouth, and throat, the ENT system. We need to focus heavily here on differentiating types of hearing loss and identifying some key pathology red flags in the throat and mouth.
Right. Let's start with hearing. It's crucial to understand that hearing works through two distinct pathways. The conductive phase involved the mechanical transmission of sound waves from the external environment through the external ear canal, vibrating the tympanic membrane, eardrum, and then being amplified across the three tiny bones, or ossicles, in the middle ear, the malleus, incus, and stapes.
So that's the mechanical part, getting sound to the inner ear.
Exactly. Then the sensorineural phase takes over. This involves the conversion of those mechanical vibrations into electrical signals within the cochlea, the snail-shaped structure in the inner ear, and then the transmission of those nerve impulses along the cochlear nerve, which is part of cranial nerve 8, the vestibulocochlear nerve, to the brain for interpretation as sound.
Okay, conductive is mechanical transmission, sensorineural is nerve transmission. The key exam skill here and clinical skill is differentiating the type of hearing loss based on the patient's history and presentation. This comes up a lot.
It's a favorite test question area for sure. Let's break down the key differences. Conductive hearing loss. This results from a problem somewhere in the external or middle ear that blocks the sound from reaching the inner ear properly. Think of common causes like excessive cerumen, earwax, impaction, otitis externa, swimmer's ear, otitis media, middle ear infection with fluid, a perforated eardrum, or otosclerosis, fixation of the stapes bone.
And the high-yield clue from the patient history.
The really distinctive clue for conductive loss is that noisy environments may actually seem to help their hearing. Why? Because people tend to speak louder in noisy places, and that louder volume can overcome the conductive block to some extent.
Okay, noisy environment helps likely conductive loss. Now, sensorineural.
Sensorineural hearing loss. This results from a problem within the inner ear, the cochlea itself, or along the auditory nerve pathway, CN to the brain. Common causes include damage from prolonged loud noise exposure, the natural aging process, presbycusis, viral infections like meningitis, Meniere's disease, or crucially damage from ototoxic medications.
Which meds are classic ototoxic agents?
Key ones to remember are aminoglycoside antibiotics, like gentamicin, high-dose aspirin, loop diuretics, like furosemide Lasix, and some chemotherapy drugs.
And the high-yield clue for sensorineural loss.
Here, patients often complain that they can hear sounds, but they have difficulty understanding speech. They might say people sound like they're mumbling. And unlike conductive loss, noisy environments typically make their hearing worse because the distortion is amplified along with the noise.
Okay, difficulty understanding speech, worsen noise, likely sensorial loss. Now, if the basic whispered voice test for screening fails, we move to the tuning fork tests, typically using a 512 Hz fork. Let's focus on interpreting the RIN test results, which compares air conduction, AC, versus bone conduction, BC.
Right. The RIN test helps differentiate conductive from sensorineural loss. You strike the fork, place it on the mastoid bone behind the ear, testing BC, ask when they stop hearing it, then immediately move the still vibrating fork near the ear canal, testing AC, and ask if they hear it now. Normal hearing result is AC-BC. Air conduction is normally more efficient than bone conduction. With conductive loss, the finding is reversed, BC-AC or BC-AC. The patient hears the sound as long or longer through the bone because the sound bypasses the obstruction in the external or middle ear and directly stimulates the intact cochlea. With conductive loss, the finding is reversed. With sensorineural loss, the normal relationship is usually preserved, AC-BC, but both air and bone conduction hearing are significantly decreased overall because the inner ear or nerve pathway itself is damaged.
ACBC is normal or sensorineural, but reduced. BC-AC means conductive loss. Got it. Now, clinically, how do we easily differentiate an infection of the external ear canal, like swimmer's ear, from a middle ear infection, otitis media, based on the physical exam?
There's a simple maneuver called the tug test. Gently pulling upward and backward on the pin of the outer ear or pressing firmly on the tragus, the small cartilage flap in front of the ear canal, will cause significant pain in acute otitis externa because you're moving the inflamed external canal. However, this maneuver is typically not painful in acute otitis media where the infection is deeper behind the eardrum. That's a key differentiator.
Tug test pain equals otitis externa. No pain equals maybe otitis media. Good tip. And just to clarify, what does the term true vertigo specifically mean?
True vertigo is not just feeling dizzy or lightheaded. It's the distinct perception or illusion of movement specifically, that the patient feels like they are rotating or spinning, or that the environment around them is rotating or spinning. This specific symptom points towards a problem in the vestibular system, usually the labyrinth in the inner ear or the vestibular portion of CN8B. Hashtag B, nose and sinuses. Okay, moving briefly to the nose and sinuses. When assessing rhinorrhea or nasal discharge, the associated symptoms are key. If the patient reports significant itching of the eyes, nose, and throat, along with clear, watery drainage and maybe sneezing, that pattern strongly favors allergic rhinitis over a simple viral infection, like the common cold.
Itching points to allergy.
Okay.
What's the most important high-yield assessment point when a patient presents with epistaxis or a nosebleed?
The absolute first step is to differentiate true epistaxis, bleeding originating from the nose, from blood that might have been coughed up from the lungs, hemoptysis, or vomited up from the stomach, hematemesis. Patients can sometimes swallow blood from a posterior nosebleed and then vomit it, confusing the picture. Once you confirm the bleeding is nasal, you need to assess for local causes within the nose, like digital trauma nose picking, dryness, inflammation, polyps, or rarely tumors. And also consider systemic causes, like bleeding disorders, anticoagulant therapy blood thinners, or severe hypertension. Hashtag TC, mouth and pharynx. All right, looking inside the mouth and pharynx. First, look closely at the gingiva, the gums. Remember that in individuals with naturally darker skin pigmentation, it's common and normal for the gingiva to be diffusely or partly brown. That's just melanin deposition. However, distinct redness, swelling, or bleeding of the gums suggests pathology, usually gingivitis or periodontitis.
Good point about normal pigmentation variations. Now, for a patient complaining of a sore throat, what are the classic combined signs and symptoms we look for that strongly suggest Group A streptococcal pharyngitis or strep throat?
The constellation of findings most suggestive of strep throat includes the presence of fever, usually 100.4 degrees FT8 or 38 degrees C, tender anterior cervical lymphadenopathy, swollen glands in the front of the neck, tonsillar exudates, white or yellow patches on the tonsils, and importantly, the absence of a cough. Having those features together increases the likelihood of strep significantly.
Fever, exudates, swollen glands, no cough equals suspect strep. Okay. What is the crucial rule or guideline regarding chronic hoarseness? When does it require urgent follow-up?
If a patient's hoarseness, a change in their voice quality, persists for more than 2 weeks, especially in an adult, they require prompt referral to an ENT specialist for laryngoscopy. This is essential to visualize the vocal cords directly and rule out potentially serious underlying conditions. These could include benign vocal cord nodules or polyps, chronic laryngitis from things like hypothyroidism or acid reflux, LPR, or most importantly, laryngeal cancer, particularly if the patient has risk factors like smoking or heavy alcohol use. Don't delay referral for hoarseness lasting over 2 weeks.
2 weeks hoarseness equal laryngoscopy referral. Got it. What about gingival hyperplasia, that noticeable overgrowth or swelling of the gums? This is frequently tested, often in relation to medication side effects. What are the key causes we need to know?
Yes, this is definitely a concept mastery alert for exams. While poor oral hygiene can contribute, the most commonly cited causes for significant gingival hyperplasia include the use of certain medications, most notably the anti-seizure drug phenytoin, brand name Dilantin. It can also be seen with some calcium channel blockers and cyclosporine. Additionally, significant gum overgrowth can occur due to hormonal changes during puberty and pregnancy. And importantly, it can also be a significant sign of certain systemic diseases, particular leukemia.
Phenytoin, puberty, pregnancy, leukemia. Okay.
Yeah.
And finally, who is considered at the highest risk for developing oral cancer, and what specific types of lesions seen in the mouth should be considered highly suspicious and warrant immediate biopsy?
The highest risk groups for oral squamous cell carcinoma include older adults, typically men more often than women, especially those over age 50 who are heavy users of tobacco, smoking or chewing, and/or heavy users of alcohol. The combination significantly increases risk. As for suspicious lesions, any persistent nodule, ulcer, or thickened patch in the mouth that doesn't heal within about 2 weeks should be evaluated. Particularly concerning are indurated, firm lesions, and lesions that appear as persistent white patches, leukoplakia or velvety red patches, erythroplakia. Erythroplakia, the red patch, actually carries an even higher risk of malignancy than leukoplakia and must be biopsied promptly. #tag potential exam questions, Chapter 12.
Okay, final systems check on ENT. Let's test those differential diagnostics.
All right, last round for recall.
Question 1. Differentiating findings. A patient presents complaining of a severe earache in their right ear. When the nurse performs the RIN test on that ear, the patient states they hear the sound conducted through the mastoid bone, BC, for approximately the same length of time as they hear it through the air next to the ear canal, AC. What specific type of hearing loss does this RIN test finding, BC, AAC, suggest in the affected ear, and why?
Question 2. Clinical tip. A patient comes in complaining of bothersome rhinorrhea, runny nose, frequent sneezing, and watery eyes during the spring season. On exam, the nurse notes diffuse swelling and paleness of the nasal mucosa. Which specific symptom, if reported by the patient, would most strongly support a diagnosis of allergic rhinitis over just a common viral upper respiratory infection, URI?
Question 3. Process action. A 58-year-old patient reports that their voice has been significantly hoarse for the past 16 days, and it hasn't shown any signs of improvement despite resting their voice. What are the 2 immediate follow-up actions or recommendations the nurse should strongly advise for this patient?
In question 4, assessment recall. When assessing a patient who presents with noticeably swollen and overgrown gums, gingival hyperplasia, the nurse carefully obtains a medication history. What single commonly used anti-seizure medication should the nurse be most concerned about as a potential iatrogenic cause of this condition? #tag outro. And there we have it. We have just rapidly synthesized some of the most complex but absolutely high-yield information from those foundational nursing assessment chapters. We've moved quickly from things like recognizing the tripod position and understanding the danger of the auscultatory gap all the way through decoding send-out and SPPIN, embracing cultural humility, to identifying the specific signs of fluid overload versus dehydration, and learning the ABCDEs and EFGs of skin cancer screening.
It's a lot, but the ultimate takeaway really is that precision in your assessment, truly knowing those underlying mechanisms, applying the correct classifications, recognizing those subtle signs that is the absolute bedrock of safe and effective nursing practice, knowing that a faint S3 heart sound isn't normal, or that persistent non-blanchable redness over a pressure point signals impending tissue damage, that knowledge is what transforms you from just a student following steps to a thinking, proactive nurse.
Absolutely. And if we kind of circle all the way back to where we started with the general survey, we identified common but non-specific symptoms like fatigue. Now, given that fatigue can be associated with so many different things, depression, anxiety, heart failure, anemia, hypothyroidism, chronic disease of the lungs, kidneys, or liver, this really raises an important final question for you, the listener, to ponder. How am I conducting a deeply detailed follow-up interview focusing specifically on things like sleep patterns, nutritional intake history, energy levels throughout the day, and performing a thorough psychosocial history actually help you, the nurse, start to triangulate the potential etiology of that fatigue? How can that detailed history help you narrow down the differential diagnoses before you even rely solely on the results from laboratory tests?
That's a great point. That proactive clinical thinking, using the history and physical exam to guide further investigation, is really what separates competent nurses from truly excellent ones. Use this deep dive as your focused study map. Go back through it, test yourself on those questions. Good luck with your study efforts, tackle those exams, and keep diving deep into the material.